Hi and welcome everyone. It's really an honor for us to join you today from the University of Washington Medical Center in Seattle, Washington. Thank you so much for inviting us to present this interesting case of transcatheter mitral valve in ring with tip to base lampoon. And we'll go over all of that business in a minute, but first let me provide a little bit of an introduction for some of my good friends and colleagues. I'm Jamie McCabe. Joining me today, Dr. Gabriel Aldea, head of CT surgery, Dr. Raf Harari, our interventional fellow, Dr. Christine Chung, one of my co-faculty here in interventional cardiology, Bailey, our technician, Dr. Logan Vincent over there, also a fellow, and then last but not least, most certainly, Dr. Burkhard Mackensen, who will be doing all the invasive imaging and anesthetics.
So what we're seeing is a mitral valve that is significant for a ring that we can clearly see indicated by the echo-dense structure on both sides of this 80-degree view on the left, almost a bicommissural view. We see smoke, spontaneous echo contrast, sluggish flow in the left atrium. We are doing a pressure half-time as illustrated in this continuous wave Doppler profile, which again, if you look at the slow reduction of the peak pressure to half of its value, gives us a calculated mitral valve opening area of 0.75 centimeters squared. One last image is a 2D biplane image that I think is of significance, as it illustrates quite nicely the length of that anterior leaflet. As you see the mitral valve here.
Yeah, quite long. At this point we have a 24 French dry seal sheath here in the right femoral vein. And that is how we're both going to do the lampoon and deliver our valve. Theoretically, you could use a slightly smaller sheath if you wanted to, but this allows us the opportunity to not change sheaths to deliver the valve. And that's really what we were going for in that sizing. We then have arterial and venous access on the left femoral, which are with lines handed off to our anesthesia colleagues so that they can monitor blood pressure and deliver drugs centrally as necessary. And then we have a radial sheath in place for the Sentinel embolic protection device. Okay, so that's our standard access configuration for a case such as this one. So we're going to deploy this, pull this wire back. We'll deploy this first basket in the innominate there, as you can see, and then we're going to bring back the articulating arm and start to bend it so that it can go up and engage the left subclavian like that. Then you can bring both arms back like this and deliver that last basket there. And now we have one basket in the left carotid and one in the innominate. Okay, so I want to be posterior and inferior, generally speaking, to try and kind of skive across the right atrium without spending any time there to speak of. So I think that's really an important aspect to these all TMVR cases, is just getting the right transseptal puncture. And if I'm not mistaken, I can see a little, he had a balloon mitral valvuloplasty performed at another hospital. It looks like they went with a very anterior puncture, didn't they? I feel like
right.
I can kind of see that.
Yes.
So that is not a space we want to use, even though they've made a hole previously and did not close it, which I'm thankful for. It is not a place that we're going to leverage because we would really pay for that. Going anterior is really challenging for TMVR cases. So that looks pretty posterior.
Yes.
And fairly inferior too, if I'm not mistaken. Yes. Okay. So I think I'm going to come out with the needle here. We'll see if we can puncture through. It's pretty thick, but needle's out. Okay, and now we're going to bovie. I'll just put it right inside this SL1 needle. See if that, nope. See the bubbles of that bovie, but that is a very stiff area. So there we go. That just punched through, I think.
Yeah, you did.
And our wire is out, and so we feel good about that. Okay. One thing that this does bring up when it's a difficult transeptal because it's been previously instrumented and so forth is thinking through what kind of septostomy balloon we're going to want to use. And I presume my catheter is across, but if you could just confirm that for me. It looks like it is. And so we're going to bring this steerable catheter in. And I'm just going to steer that down and lock it as I pull this guy back. Okay. All right. So there's our mitral gradient. So we're going to take a balloon wedge catheter in through the steerable catheter to get across the mitral valve, and the point here is to not get caught in all of the subvalvular apparatus. You can pick the balloon up there. There we go. So here we have our kind of long axis view of the mitral valve, and you can see on TE, which Burkhard has so nicely provided us, the sort of surgeon's view from the left atrium down, that we're posterior here on the in terms of crossing. So with the little clockwise rotation, whoops, I went too far. Let me take off some of this guy. A little clockwise.
You're across.
And here we go. And you can see that on TE quite nicely. Not it. Sorry for that ectopy. That's on the aortic valve. Okay. So
you might have it.
Yeah, I'm going to just fold this guy down. So this directional catheter is buttressing us so that we're not messing around in the left atrium, which can sometimes happen in these very large left atria. And then we may probably already have snared this guy. Or, yeah.
Yep.
Okay, so I'm going to pull this back and just pull this guy forward a little bit. Will you hold this part of the wire?
Mm-hmm.
Okay, and I'm just going to try and... There we go. So that came right back, okay? Okay. So the Estado wire is the wire that we typically use for Lampoon. It is a tip-to-core construction, which means that it has a single contiguous metal. Oops, I missed it. Contiguous metal construction, which allows for the transmission of electricity. And we're just trying to snare that guy like that. Okay, so we can flow restore that. So we've snared this Estado wire, and I'm just going to internalize that wire a little bit like that, like so. And we're going to leave everything there for a minute, because now what we want to do is we want to make what's called a flying V. So we're going to, this is a 300 millimeter Estado wire. We've got a 150 millimeter plastic microcatheter on it. In this case, it's called a piggyback catheter, but any non-metallic braided microcatheter will do. And we're going to walk this microcatheter back to the end of the wire. Therefore, the tip of the microcatheter is going to designate the kind of halfway point of the wire. So let's walk this guy back carefully, if you wouldn't mind, Dr. Aldea. Excuse me. Before we fully externalize this wire, we're going to make what's called a flying V. So this wire is PTFE coated. That's the green coating on it, and that is that protects it, but also means that it will not conduct electricity well. So we're going to scrape some of that PTFE coating off with a standard blade, like this, and just denude it about a centimeter or so. Make sure that it's well denuded, and then in that spot that's been denuded, we're going to bend it into a sharp V. Okay. And that's the so-called flying V, which will be the spot that will lacerate the mitral leaflet. Now, we want to bring the microcatheter forward so that only a little bit of this V is protruding, and then we're going to lock this position in place. So we're going to do that on the back end by locking the microcatheter and then taking a torquer, standard torquer, And we're just going to put it on the back end of the wire right at the microcatheter so that this relationship between the microcatheter and the V is maintained. And I don't know if you can zoom in on this for a sec if you wouldn't mind. You know, the microcatheter itself is maybe, I don't know, 2-3 millimeters back from the V tip there, as you can see, right?
Okay. So
All right, great. So now we've externalized the wire, and let's take a
hemostat.
a hemostat. Yeah, that'd be great. And just to make sure we
I
don't
have
lose
an
it.
extra hemostat.
So now we've got both ends of the wire here, but what we still need to
Couple
do
of
is
hemostats.
get the V in across the mitral leaflet. And so we're going to be looking for the little fluoroscopic marker. Yeah.
So I still think, from my point of view, you're relatively towards the medial commissure
Okay.
and not the bulk of the length of A2,
Okay.
if that's possible from your perspective as well.
That is possible. So if we wanted to go more lateral, I could straighten out this shaped catheter in the mitral, which will extend us more laterally. All right. And we're going to mag in here just so that we can see everything a little better. Now, one thing about doing this tip-to-base lampoon is that you really have to be careful to protect the aortic valve. Right? So the catheter on the arterial side needs to be across the aortic valve and insulating the wire and thereby protecting the aortic valve so that it's just exposed in the atrium. Now, one thing I don't see at the moment is the actual V, which I think probably needs to go this way. There it is. Okay.
I think you're now in a better position. I see it actually from the ventricular side.
Great. So I'm going to pull this back a little bit. I'm going to send this guy forward a little bit across the mitral. Okay, so now in this view, if we look closely, and I'm going to do this on Cine so you can see it, you can see that you can see the dot of the microcatheter down across the mitral valve in the LVOT, in the left ventricle, and then you can see that V shape that we made in the wire is there at the tip. So first things first, I want to make sure that I've taken the slack out of the system. And Dr. Aldea is going to hook up the end of this wire to the Bovie catheter so that it can be electrified. There we go. So I'm going to do a little preliminary tug and just make sure that everything is coming together normally. Okay, it is. So I think we can go ahead and do the arterial ones too. All right, thank you. So I think we can go ahead and do the laceration now. Everyone ready?
Yep.
Okay. Bovie on. Bovie off. Okay, and let's just have. We'll use TE for confirmation that we've lacerated it and we've got MR.
Let's look 3D.
There, I think you can see a cleft in that anterior leaflet, if I'm not, or is that a shadow? Looks like a cleft to me.
Now at times we see also that the leaflet, even though it's lacerated, kind of comes together and
stays sort of intact
exactly.
just because it's so stiff.
Functionally stays somewhat intact.
Yeah. Well, I think
if you could move your balloon a little bit, or your catheter, sorry.
Yeah, do you want me to pull it back?
Then
here?
I could maybe exclude that it's not a shadow we've seen.
So here, and here's the catheter going away.
That's a tear.
And I'm going to flip this. Yeah, I do see some added mobility here.
Straight wire, and I'm going to let the balloon down here because we're going to flop into the LV apex like that. Okay, and you can walk that back. So we're going to do a balloon septostomy here. And in this case, we can do it actually through the directional catheter. It just means that you don't fight against getting the balloon in across the thickened septum. So let's just go. So So I'll just bring our balloon in here, and we can put it in the mitral valve first, and then we're going to walk our septostomy, our steerable catheter backwards. If you want to do the mitral valve one time, you're welcome to. Go ahead. Just do that. Okay, that's good. And then we'll walk it back into the septum, which should be right about there. Why don't we go ahead there, up with the balloon, yeah. So there's our septostomy, and we'll just do it a couple times and make sure that we really got it.
Okay.
So, in this case, we have a 29 millimeter Sapien Edwards valve that is mounted upside down from the standard TAVR orientation so that we don't put it in backwards, basically. This is a balloon expandable valve platform that I would imagine most people are familiar with at this point. So watch that wire.
Wire back.
Yeah, we really need to be careful with that, okay? 216, if you could give another 3,000 of heparin, that'd be great. I'm gonna go this way. And you can start to come back here, Gabriel. As you come back, I'll come out. Okay. Go ahead.
Okay, coming in a balloon.
Okay, good. So, thank you. So the key to these is to start spinning the catheter, in terms of delivery, start spinning it in the IVC so that as it comes up into the atrium, it spends as little time there as possible. And it is going to rotate itself, typically. Okay. There we go.
Okay.
Okay. So that is a really nasty feeling interatrial septum, I must say. Oh gosh. That was a bit more of a fight than I would like it to be. So we're going to pull the pusher back, which is required to make sure that you expose the balloon. And then I'm going to undo the curve on it, which I think helps just push it into kind of its lateral perspective, lateral commissure. So our valve has some parallax in it, and you can tell because the ends of the valve are not squared off. What we're going to do is kind of do a push-push as we slowly inflate, by which I mean I'm going to push the delivery system and the wire at the same time. Why don't you go ahead on, or is that you? Okay. Go ahead, Gabriel. Good. Go up to one. No. Shit.
Deflate?
Deflate, yeah. Just a little bit. Okay, now. Okay, go up again. Good. Okay, down. Just like you draw it up. Pacer off. Okay, we're going to let him recover for just a minute. Well, you don't land it much better than that. Okay, so this is going to be our outflow track, our resultant outflow track gradient. So there is some gradient there, certainly. Just speaks to the need for LAMPOON and or alcohol septal ablation and really paying attention to these folks, because even though we measured an outflow track, a neo LVOT of 225, which should by all rights be fine, it's not perfect. Thank you. Okay, and here is our mitral, and so it looks like we are gradient free across the mitral at this point. There is still that V wave in the left atrial tracing, which is interesting. You know, there isn't, I'll corroborate, but I would imagine there is not significant mitral regurgitation. I think that V wave just represents sort of diastolic dysfunction and poor left atrial compliance, which a lot of these sicker folks have. Any thoughts about that, Christine, and how you sort of approach these afterwards? I've wondered if perhaps when you see a V wave like that, not closing the intraatrial septum would make sense because it acts as kind of a pop-off valve for the diastolic dysfunction. But do you have any thoughts on that one?
Are we able to visualize much MR on color Doppler?
I would bet you there's next to none. But Burkhard, would you give us a sense for the MR, if any? And I'm going to pull back out from across the valve. So nothing across the valve at this point.
Yeah. Yeah, no, I think it makes sense that there is a chronically stiffened left atrium, and it's just going to be more sensitive to small changes in pressure.
Yeah. Okay, so I think at this point now the question becomes, well, do we want to close this intraatrial septum? There's not anything further I'd like to do for the mitral valve. So a couple things that we normally check would be the direction of shunting. So is it to the left or to the right? And then also how bad is the tricuspid regurgitation or the pulmonary hypertension? And so we obviously leverage our echo colleagues for this information. Looks like that's all left to right at this point, and which would be consistent with this idea of a pop-off valve for the intraatrial septum for diastolic dysfunction. And I think that's probably a bonus, a little side bonus for these cases. So, so to get the Sentinel out, you just sort of work backwards. You take the left carotid. Basket back, you bring the whole system down so that it can unfurl,
you hold the bench,
straighten, and then capture that last basket, and out she comes. So, and then let's see if we got anything here, because these are cases where you can often, oh boy, see something, but it doesn't. It's not going to come out because it's broken. So a little bit of shrapnel in there, you know, a couple little pieces. And this guy is, really want to come out. So not much in this one. Well, except for this little guy. Look at that.
Wow, that's a big chunk.
That is a very, so where'd it go? This on my thumb here was in that basket. So that is, that's no joke. And I will say that, there you go, that in these settings of doing lampoon or laceration or basilica, any kind of laceration, you can often find really large bits of debris in there. And that's...
essentially looking at the aortic valve here, which is nicely opening at the end of the case. The tricuspid valve to the left, there's still a few bubbles, probably some medication going in. If I now do an en-face orientation, I have the aortic valve now at 12 o'clock and the mitral at the bottom. You see and appreciate how nicely it opens up for orientation. The transseptal position was exactly there. You still see the hole right there. Now with that left to right shunt. If I look at the 2D with color, here's one example where we certainly appreciate how the valve is coming down here. If I take the color away for one moment, see here, the length of the valve is seen, the mitral valve leaflets are opening, and then at the tail end you still see pieces of that anterior leaflet, and then the aortic valve. That, and you see a nice laminar flow falling through the mitral valve in the center, and no evidence for any leakage. Velocities are a little bit above 120, but I think it's not going to be more than 3 or 4. 3.
Terrific. Okay, well with that we're going to take out a couple of IVs here, and then I think we're done. And for my colleagues, Dr. Mackensen, Dr. Aldea, Dr. Chung, Dr. Harari, the strong and silent type, Dr. Logan Vincent on the end, and Bailey, really an honor for us to be here. Come on up here, Raf. Really an honor for us to be invited to participate, and thank you so much, and I hope you enjoyed it.